So I'll first start by introducing Dr. Fukaya and Abby Pandya, who are at Stanford Healthcare. Dr. Fukaya is a vascular medicine specialist, and Abby is, what would you call yourself?
So I lead the product management function of our data
Maybe you
science
should
team.
introduce yourself.
Yeah.
Sorry. Abby has just been super helpful in getting the translation of the models going, and you guys all know Dr. Catherine. I'm going to butcher your last name. McGinnigal.
It's a mouthful.
Yeah, who's a vascular surgeon and research scientist in North Carolina, who's going to talk about her work that was funded through the foundation.
Good morning. So my name is Artery Fukaya. I'm a vascular medicine specialist at Stanford, and I've been lucky enough to work with Dr. Ross right until she moved to San Diego last year. So I've worked with her for many years, know her work really well, and we've always really talked a lot about implementing AI in PAD or other vascular diseases. So what I did was, after she left, kind of took on her project that Stanford really wanted to support and try to really be helpful in the implementation part. Do you have the slides, please? Thank you. So what happened is Dr. Ross's work has always been greatly recognized at Stanford, and when Stanford was trying to pick AI initiative program to support, Dr. Ross's program was one of the ones that they wanted to support. So they came up with a data science team led by Abby to work with the clinical implementation team, which would be me in the vascular clinic, to see if we can run this work at Stanford. And there were a lot of calculations done prior to this to see if this was would make sense for the health system to support financially, and I don't know exactly how they did the numbers, but they did, decide that it was something worth supporting. Unfortunately for health system, most of the times it's more about will it benefit or support them financially, no matter how much they say it's about patient care. If it doesn't make financial support, it's not going to be supported. So just to give you a little bit of background of what kind of patient population Stanford serves, we are 35 miles south of here from San Francisco. We're right in the middle of Silicon Valley. We are located right in between two counties, San Mateo County and Santa Clara County. San Mateo County and Santa Clara County, both of them, the population breakup, the top three are white, Asian, and Hispanic. In San Mateo County, the white population is about 38%, followed by Asians about 26%, and Hispanics about 24%. In Santa Clara County, the highest is actually Asians, about 45%. White people are about 35%, and then Hispanics about 15%. And in both counties, the black non-Hispanic population is less than 2%. The median area household income in Santa Clara is approximately $180,000, and San Mateo County is about $150,000. So that kind of, it doesn't give you a whole lot of information, but you might get an idea of what kind of people might be living there compared to other places. In Stanford Healthcare, because it sits right in the middle of those two counties, we serve both counties, and obviously the people come from further, but that is the majority of the population that we serve. And if you think about, I don't need to tell you, this audience, why we need to screen for PAD and why it's important we detect these people and want to provide care. But if you really think about PAD, there's a lot of disparities in care, access to care problems, socioeconomic differences in access to care, all of those things. And looking at the population of who is most at high risk for PAD, it's black non-Hispanic women over the age of 70, which really doesn't fit our demographic population quite as well. But with that in mind, I wanted to give you kind of an idea of what we've done, what our challenges have been, what we've been successful in, and then wanted to have an open discussion about your thoughts, and we have great minds here, so what suggestions you may have for us. So the current workflow, as a lot of it was described by Dr. Ross, we wanted to use her model that was initially developed, and the data science team worked on it a lot more, to find patients who had PAD in our healthcare system. So it's really limited to the Stanford EHR, and then within that, identify the PAD patient models. And then me being a vascular medicine specialist and this being very close to my heart of something what I wanted to do, it's very, very involved with the clinical team. So we wanted to have a vascular provider involved. We wanted to have their primary care doctor involved to provide comprehensive care, and we really wanted to have the patient involved. And so it was all these parties being involved. And so I'm gonna, before we go on further in terms of the actual workflow, I'm going to have Abby describe a little bit of how the data science team worked on this.
Thanks, Dr. Fukaya, and good morning. Next slide. So at Stanford Healthcare, how do we cross this implementation valley, so to speak? Like, what are we doing for the models, and particularly for the PAD AI-guided workflow? We really consider, beyond the model, what is the overall workflow that it's being put into place around, what's the action, the people needed, the stakeholders, and then what are some of the policy and capacity considerations and constraints. And so through this, as Dr. Ross already mentioned, we have a firm assessment standing for the fairness, usefulness, and reliability of AI models, which has 3 parts to it. And we are bringing this forward in our responsible AI lifecycle as a health system, being able to do some rigorous upfront analysis, as well as monitoring and evaluation over time. And so for the PAD model, we did the firm 1, which really covers the what and the why. So getting into the problem of undiagnosed PAD in our population, the need and the use case, being able to drive a model's output to run a patient list that then is acted on by the vascular medicine MA, and then eventually brought through, as Dr. Fukaya is going to walk through again. As part of this firm stage 1, which is what was brought to our data science executive committee for approval and green light, there's the business case, the financials, about what it means for deploying this model, the resources required. There is also an assessment on the utility, so being able to simulate, given this workflow and actions and constraints, what is the kind of net benefit or gain, and where does it make sense to have this insight surfaced. And of course, the ethical considerations, really taking into the perspective of the clinician, the model developers, and our patients, being able to understand stakeholders, alignments, and incentives. Firm part 2 is that implementation valley, being able to translate the model to our production system. So run on production data, driving a workflow, building additional components to get that in place, but then also translating the workflow into something that we could bring forward operationally, taking into consideration kind of the needs of the stakeholders. And then we of course have the firm part 3, which is the impact. So having a monitoring and evaluation plan in place, not only for the model performance, but the workflow conversion, and then the kind of prospective evaluation over time. So how do we actually kind of get to the actionable, reachable population at Stanford? The model helps to identify, narrow down our starting point of patients and providers to reach out to. So who's the first 1, who's the first 10, who's the first 30 patients that we can really bring through. And we tied this workflow, as mentioned, to the primary care provider. So that did limit kind of our scope and our reach, because 2/3 of the patients had primary care providers. And then for every patient, or for every 6 patients we would bring in to have ABI, TBI, we anticipated finding 1. And then we of course know that the actual numbers were going to be lower due to kind of conversion and drop off of the workflow. And I'll hand it over back to you.
Thank you. So the workflow was, again, it started with the model. The model would provide data about which patients might be doable. And what we did was we actually did a lot of beta testing, so see if the model works. So we came up with a green light, yellow light, red light. So let's say the model came up with 10 patients. I would physically go through each patient and look to see if this was green, meaning from a clinical standpoint, this person really has a lot of risk factors. There's a lot of things that might really require screening for a PAD. Versus yellow, maybe, maybe not. It's hard to say. Red is like definitely not really a screening applicable patient. So we after the initial model, we fine-tuned it a little bit with this green light, yellow light, red light, and then so that's how we came up with the model. We did a lot of beta testing around that. And then after that, we wanted to develop a workflow of, okay, the model picked up the patient. How do we get to the point of screening them? It's working in the trenches, you realize there's a lot of hurdles that you wouldn't have thought of if you were just thinking about the workflow. So first of all, who is going to reach out to the patient? Is the patient going to be offended if somebody just reached out to them and said, you need to be screened for PAD, and PAD is scary because you could use your limb? Like, what kind of effect would that have on the patients? Then there's the financial implication to the patient of what's the cost of them for being screened, and what's the cost of them being put on a medication they don't really want to be on, and what's all the follow-up there is stigmatized with a disease. Is that really good for the patient or not? We think so, but maybe from the patient's perspective, it might not be. And then we actually had a lot of pushback from the primary care physicians in ways that we did not realize we would get pushback from. So if we go out saying to primary care physicians, PAD is really important to diagnose. These patients are not only can they lose their limbs and have devastating consequences of limb-threatening ischemia, they also have higher risks of stroke, heart attacks. And we thought that message would get the primary care physicians on board, saying, yes, that's something we should screen for. But a lot of the response we got was, yeah, that's important, we get that, but there's a lot of things that's important. And one of the biggest hurdles we faced was that PAD is not recommended per the USPTF task force. And in 2018, there was a second push to do ABI screening, and the USPTF task force pretty much shut it down, saying there was no evidence to recommend ABI screening. So one of my personal motivations of getting involved in the study initially was, well, maybe doing studies like this can build the evidence for the screening. However, because it's not in the screening, the PCP, it's not important to the PCPs. They have a whole list of things they want to do. So it was really, some PCPs are on board, but a lot of them are like, I really don't want to deal with this. And if they get diagnosed, they don't need interventions. Like, what am I going to do with it? Was kind of a lot of the pushback we got. And even if in places like Stanford, where we say we have vascular support, we have a vascular team that can help manage, they really weren't motivated to diagnose these patients, which was a little bit surprising. A lot of us in cardiovascular, we go to AHA, we see a lot of vascular initiatives, and AHA recommends that if you're age over 65 and you have comorbidities like hypertension, hyperlipidemia, smoking, family history, other disease in cardiovascular vascular beds, you should be screened. But that's a recommendation and not a USPTF guideline. So it really doesn't resonate with the primary care physicians.
Dr. Fukaya, we have about a minute left.
Okay.
What other insights?
Okay, sorry, I got too excited about this, sorry. Because that was actually the biggest hurdle of everything. But then we did a workflow where we reach out to the primary care. If we were able to get their buy-in and have them on board, then our team, MAs, reached out to the patient. They would get to see if the patients were interested. And if the patients were interested, we got them in to do the ABI, TBI screening. And depending on what they did, whether they had disease, whether they didn't have disease, if they had risk factors, we would give them vascular counseling. Because part of it is the awareness of knowing that there's PAD out there. So that's what our workflow was. And I am going to, this is really our last slide, so don't worry, we're not going too much over time. So one of the challenges we really faced, and it's at the top here, is inconsistent clinical guidelines and recommendations. So people just weren't really interested in screening. And, you know, like, they're on a statin already, they're taking blood pressure medications, and it might not be guideline recommended high-intensity statin therapy, but they're on statin. Their LDL is not perfect, but it's about, 110, like, why do we need to do more? It's kind of the pushback we got. And it's really hard to convince people in like a 5-minute, 10-minute timeline when, for us, when we see the end stages of PAD, we think it's so important. But for a lot of people, other things are important. And the other thing is the actual workflow. So, okay, let's say there's a patient, and I think it was sort of along the questions you asked, is you have a patient you want to do ABI, TBI screening for, but how are you going to code that so that it gets reimbursed? They don't have claudication, they just have risk factors. You really need like leg pain or some other kind of diagnosis that is goes with the CPT codes. You need the ICD code that goes with the CPT code for the ABI testing. And how do we work around that? If a patient doesn't have PAD yet and they're not complaining of leg symptoms, how do we get that? And then also, because we were doing a referral base, we can't just go out and randomly order tests for people. We needed a referral, and most insurances will require primary care physician referrals. So how do we get around that without getting primary care buy-in? And what is the cost to the patient? If we could just say, okay, an ABI test is $30 or $50 across the board, it's easy. But for some patients, they may pay nothing, and some people, it may be hundreds of dollars. It just depends on what your insurance coverage. And it was very hard for us to know exactly how much financial burden it would be to the patient. So there were just a lot of challenges that way, and we are trying to work around that, but would love to get your input. And I'll let Abby finish up here.
So our first two challenges, we kind of had a strategy to approach it. Our last one is still very much a work in progress. And I'll just leave with kind of 2 points. One is being able to get to who are the actionable patients, how can we reach them, and what pull, if any, there that exists from all of the stakeholders that need to be aligned to be able to get there. And then lastly, really the limitations of a data-driven approach. And Dr. Conte, you touched on this in your introduction, that we can action forward patients that we know of in our health system and who are interacting with our health system, but that only takes us so far. So thank you, and looking forward to the discussion.
All right, we'll move on to Dr. McGingle's presentation so that we have time, and then we can reserve questions at the end, till the end.
All right, thank you very much for having me. I have to say, like, the view this direction is just so gorgeous, and I'm really excited for Circulate tonight, because I assume then the view's going to be out that direction to the bay, which is equally as gorgeous. I feel very lucky to be here, and I'm going to give you a talk that's titled Developing a Flexible Statistical Framework to Accelerate Data-Driven Treatment Algorithms for Peripheral Artery Disease. I've got a couple of disclosures, but really what I want to do is thank the Binkley family for the Binkley Research Award, and also the Foundation to Advance Vascular Cures, because they funded a grant with that title, despite its verbosity. And that's what I'm going to talk to you about today. And so just by very brief outline, and I will stick to the 10 minutes, Isabel, the key unmet needs in PAD, my project goals, and then the impact I hope to have on the field with the help of all of you. And so from the global guidelines themselves, the conclusion of that really awesome guidelines is that what is lacking from a uniform definition of clinical stages of disease, key patient-focused outcomes, contributing to an incomplete picture of the epidemiology of CLTI, and a limited evidence base to guide daily practice. That's a pretty damning statement, but when I read it, I thought to myself, I'm still pretty young. I got the energy to fix that. And I've been chipping away at it ever since. And we've kind of hit on this already a few times. The evidence base for PAD is really poor. We have inconsistent nomenclature. 96% of the trials in PAD are industry sponsored, and they still use Rutherford classification in those trials, and so we don't actually even know the patients that they're treating. Best CLI is the only trial we have that has Wi-Fi included in it, and that's one trial, as important as it was. None of these trials have appropriate representations of female and people of color. So we've got a ton of problems, and therefore we have weak guidelines. Therefore the USPSTF doesn't know how to make recommendations. And we don't have a sense of how to regularly measure what comprehensive treatment is and what are the most important outcomes. I would say CLTI-free survival is a really good outcome that we need to focus on personally. So weak guidelines lead to lots of room for interpretation, which leads to lots of room for bias, and the personalized treatment recommendations that we're all working very hard to give are usually based on not data-driven things. Things like social circumstances or existing therapeutic relationships. And unfortunately, in the United States, that leads to less aggressive care for females and persons of color, and especially for older Black women, if you happen to have that intersectionality. And so the result of that is that folks are just ping-ponging around through our clinics, like in this figure, and unfortunate numbers of them go to major amputation instead of stable CLTI-free survival. And so my proposed solution with this grant is to standardize vascular-specific nomenclature for EHR data, and to then identify high-impact features in that EHR data that we can use for different interventions, precision medicine or otherwise. And so I'm going to take this a little bit out of the 30,000-foot view and talk a little bit more specifically about the data science lab at UNC that I'm partnered with and what we're actually doing. So the base of this work is based on OMOP, which is the Observational Medical Outcomes Partnership. And this has really become the international standard for EHR data architecture. It's used both in industry and academia internationally. And the idea here is that with this petabytes of data that we're all generating, you can't really do anything scalable or reproducible unless we're organizing all of that data in a standardized way. And so, in OMOP, all of the patient encounters, all of their vital signs, all of their lab values, all of the devices they've had interactions with, some of their radiographic studies, where that health care was received. All of that is all standardized with this standardized vocabulary. The problem is that there's not a lot of specialty-specific information. And so in the case of PAD and vascular surgery in general, it does not include peripheral vascular lab data. And there's a few other factors, too, that we found that are not included in OMOP. And so that means that we can't really do scalable, reproducible healthcare data analysis. So we need a vascular extension to this. And so that's what I'm working on. And this is it. This is the tedium. And this looks a whole lot like what a lot of you have done. In fact, cited here are people in this audience. Paula is smiling because she recognizes this table. She and I made this together to try to figure out all of the codes that were related to a project that we were doing to measure amputation. And so we've been back and forth, and so I went through all of the literature to try to find all of the codes that everyone has used, and lo and behold, each paper uses a slightly different definition. And we came up with this huge list of codes, and I handed that over to the data science team. And then they responded, well, do we really care what concepts in OMOP these codes map to? What if there's other incremental codes that are picked up in other concepts? How should we relate those things together? And so this is the back and forth that we are doing. This notably does not look like one of those fancy, like semi-invisible men floating around in space over Silicon Valley. This is really, really tedious, but it's also very, very important human work to make sure that we get this done properly. And so then we kind of have this broad ICD-based area that we're going to put into the OMOP system at UNC. But I'm constantly tasked with, do we have the right codes included? And so I've been talking to everybody I know and hitting PubMed as much as I can. And this is also very importantly for this organization, where we get patient input. And so on a variety of my different patient stakeholders that I use for various projects, I talk to them. And one of them, who has a combination of diabetes, diabetic foot ulcer, and then ultimately ischemic wounds and more ischemia-driven ulcers, she said that she can't really understand the difference between pressure wounds, diabetic foot wounds, and arterial wounds. And I was like, well, you've been my patient for like a decade now, and like I thought we really had kind of gotten over that hurdle. But if you, who's been so involved with me clinically and in research, doesn't get it still, then surely nobody else is either. And so we actually expanded out and included a lot more kind of adjacent ulcer codes to make sure that we had a really comprehensive group of patients in this vascular extension. And then based on the actual specific studies we want to do, we can kind of pair that with PVL measurements or other findings that might kind of help delineate a specific analytic data set. So we're doing that. We're getting all of the PVL measurements. We're trying to decide what specific other radiographic measurements we think are important. And then we're going to model this in the OMOP architectural way. And then we're going to test it in a bunch of other places and have a bunch of other people try to find all of my false assumptions. And then ultimately, what this is going to look like for us who want to do the research is that you have your patient cohort identified, and then all of this data architecture is going to go on secretly in the background, but at least now you kind of know what the metastructure looks like. And then we'll see our standard line item that we're used to, a patient ID, their age, the date of diagnosis, demographics, you know, and like key covariates. So aim 2 is to use all of this, at least within the UNC system, and to identify which are the high impact features. Because of course now we're going to be dealing with hundreds of thousands of variables, and we all have a sense, like, well, diabetes is important, renal disease is important, especially if you have medial calcinosis, but which one of those things individually, incrementally, if you can only tackle one thing, because doing things in the community is actually really hard, which is going to have the biggest impact. And so if we can figure out which variables and variable domains have the highest impact on CLTI-free survival, or whatever your outcome of interest is, then we can use a data-driven approach to figure out which clinical trials are going to have the biggest bang for the buck. Certainly best CLI was important in endo versus open, but there's so much more. And knowing what is the second most important question for another really expensive trial, it seems like it's important information to know. And then we can also figure out, based on the demographics of your population, what are the implementation projects that you should prioritize first and what you expect the incremental change to be. And I, again, would like to tell you that this is just like some like really jazzy, transparent man floating over Silicon Valley, but like this is what this looks like. This is the proposed statistical framework that we're kind of starting to work through. And next year I'll be able to give you the answer to some of these questions as we finish. I'm just 6 months into this award so far. And so the impact on the field, I think, is mostly on this first aim that I've been working through, because I really believe that having a standardized EHR data language means that all of us don't have to reinvent the wheel every single time we want to do a project. And so it should really facilitate and accelerate all future projects. And I see this first step as the first brick in the foundation of a national multi-site networked EHR system and research core, very similar to what they have for the COVID collaborative and other integrated research networks that have been spurred on by health problems and our abundance of data. So, thank you so much, and I'm going to have to get you to join me if it's going to work.
Thank you. And I said your name wrong again, so I'm just going to say thank you. Isabel, how much time do we have for questions? Yeah, I'd like to keep it under 10 minutes. Okay. All right. And then Dr. Patel, did you want to join the panel, or are you going to hang out? We have microphones. Yeah. Oh, yeah. There's someone walking. There's a microphone.
So, it's Gail Tang from Seattle and University of Washington and VA. I'm a little surprised that you had so much resistance from your primary care providers in saying no intervention for asymptomatic patients, Because I think we've all been saying that these patients need intensive medical management, their LDL, threshold is actually less than 70, it's way lower than even the CAD or carotid patients. Blood pressure control, diabetes control. So why do you think the primary care providers are so resistant?
I think the biggest thing is they don't really see PAD patients primarily. We see them all the time, so we know the bad consequences. We know they need, but again, it's a priority thing. If they have 10 things they need to check off, and they don't have that big panel of PAD patients, it's not a priority, unfortunately.
I'll just say one thing. I know there's about 2 more questions quickly. I wasn't surprised. I mean, I don't mean that in a bad way. My wife's a primary care physician. I mean, we should be clear, and I'll ask some controversial questions of the group. Is PAD a different disease than CAD? Because the primary care doctor is not seeing it as such. And so if they're seeing it the same and you're saying, hey, they should be on statin, they should be on blood pressure management, I'm telling you your patient has something that you already think they might have or they have risk factors for, their simple question to us might be, what am I going to do differently? Now, there are things we're going to do differently, but we should be very direct about what we think that's going to be.
Sorry, go ahead.
Sorry. I want to add to your background section for the next thing you're going to write on that question. So absolutely agree with Dr. Patel about this issue. So I just spent 3 years in rural West Virginia implementing diabetic foot exams with primary care providers. And the only reason they did it was because, again, I decided to go the diabetes route because it's already a quality measure, and from an implementation science standpoint, there's more motivation when you look at frameworks and things for that kind of thing. But what they were doing wasn't effective, right? They were checking a box and not doing the thing. And as soon as we helped them and talked to them and asked them, how can we make this better and more effective, that's where we started making change. It was great. We found significant decreases in admissions to hospitals, all of that good stuff. I brought that to the FQHC, to the other clinics that I was working with. I was like, here's the information. These 2 clinics are doing great. Let's do it in your 12 clinics. And they said, we don't have time to do that. We have this huge checklist. And in fact, my clinics I worked with fell behind in our other measures because they were spending time with this measure. So it's a great question that we have to deal with when we're working with this issue.
And can I make one comment about what you said? It is in internal medicine checklist to do foot checks for diabetic patients, but in internal medicine, it's taught that you're looking for like fungus in between the toes. You're not doing a vascular exam.
There's lots of good questions still.
Yeah, so, I was struck by the talks because you guys came at this from multiple different angles, right? There are folks that, like Kate, that talked about CLTI. Dr. Ross, you talked about, basically asymptomatic PAD, detecting it early on when the patient doesn't have it. Talks were also included about, how do we disseminate this in the community? And fundamentally, we all believe that PAD is different than CAD and other forms of vascular disease, right? So one thing that stood out is, our inability to be able to code and get reimbursed for simple tests that have been around forever, like ABIs and TBIs, for screening purposes, despite having numerous trials and numerous assessments of that technology in that population. What can we do to improve that pain point, that friction point? Why can't we get, for example, an ABI, TBI test approved with a CPT code to be reimbursed for screening asymptomatic individuals?
I mean, honestly, I think it's because we don't have enough evidence base. And we do have some studies, right? And so people who are going to be believers are writing these papers, and the people who are believers are reading these papers, but they're still not the level 1A evidence. Like when you compare this to something like a diabetes population, there's a bajillion patients and a bajillion studies, right? When you go into a cardiology clinic, the question is what clinical trial do you want to participate in? And it's not the same. And so we think we have evidence because it's a heck of a lot more than we had 10 and 20 years ago, but it's still not the same level of population evidence. And I mean, that's one of the things that I'm hoping through this group, we can facilitate the use of broad EHR data to generate high quality retrospective data to kind of pinpoint what merits a prospective trial, or maybe just to kind of finally convince people that there's a return on investment to get the CPT codes and the reimbursement. I mean, I would love to see CMS not reimburse for PAD unless you put in a Wi-Fi score. Then everyone would start to use Wi-Fi, and we'd actually like know who we're studying for what, when.
Yeah, I think we have to tie it to a therapy. So we're talking about a diagnostic test that in screening, at least in large groups, and is controversial about whether, at least USPTF is saying don't screen asymptomatically because you can do the usual therapies. What's really awesome right now is we're about to be where we can change the future of cardiovascular medicine, including in the limb, if we tie it to specific therapies. We can give somebody a shot twice a year that gets their LDL below 40. The greatest discoveries in healthcare aren't getting to the people that need it the most. The vascular patients that need that therapy. You did a revascularization, stop talking about a statin, inject them. Tie it to an ABI. Tie these therapies that take away adherence issues. Obviously, there's got to be a business case. There's got to be a design issue. Once that happens, then therapies come. We got to checking LDLs because we had a therapy for LDLs. We got to doing other things because we had a therapy. I'm not suggesting there aren't therapies for CLT. I know the things, but I'm just saying for the asymptomatic PAD patient right now, we haven't been clear enough yet about that.
Dr. King?
Thank you. Sharon Kang from the Loma Linda VA. So when I listen to the panelists' message overall, right, we have multifaceted obstacles from poor, maybe, or even available good clinical trials. There's systemic processes, buy-ins from the PMD, insurance-based issues for referral, and I think those are all important. I'm going to step back because I work in a controlled healthcare system. Essentially, the VA is an all-encompassing service, right? We function as a high specialty hospital in addition to being basically a safety net hospital for all the veterans. So I'm just going to talk about some observations I've had running the vascular service, is that it was and is an enormous divide between subspecialty care and primary care. This is not to knock primary care doctors. They are critically important as a mass workforce to treat the global population. But when it comes to subspecialty medicine, like vascular surgery, they have what I see as an educational deficit from where we have been when they were maybe in school and training to where we are now. And we used to go and give talks to the departments to bring them to speed. But then the second thing is they're way overworked. They're forced to see so many patients, they don't have time. So when every referral comes to my limb clinic as claudication, ischemic breast pain, and acute leg, that's simply impossible. The patient has all three. And especially when I walk in the room and I can see basically a pulsating pedal pulse, right? When it's that obvious, it tells me that they're not really seeing these patients or not having the time or not understanding what this means. So speaking from a systems processes issues, our service decided to basically act as a pseudo primary care doctor. So we did all the screenings, we wrote the letters, we mailed it to them, we called them, we notified them, we documented, blah, 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 blah. And what we noticed was there was incredible buy-in for the patients at that level. So I wonder if the pivotal point for us is in not just engaging PMD, I think we have to do that, but focus a large part of our energy to integrating the patients. As some of you have alluded to, they're the ones most invested. There is a significant portion of patients and veterans who don't want anything to do with us, and that won't matter whether the PMD alerted them or I alerted them. They're not coming, they're not stopping the smoking. But what we did was take a very granular approach. We manage and do all our own lipid screenings, our medication adjustments, our surveillances, and all the work. And that comes with institutional buy-in, right? So I had to hire a whole 2 new NPs just to run that entire thing. And I listen to all of you, and I wonder where we can, at each pivotal point you guys talked about, focusing all on the recipients of this, which is the patient, because when the pressure from, I guess, the clients grow, that may be a different way to force the pressure points of all these other little obstacles you guys are talking about. So I guess my question, despite that long oratory, is what's your next step maybe to engage that part? What more can we do? I understand the AI part, getting IT savvy clients, or that's what we call them at the VA now, clients, to engage more with us. But at other different points, like from a process standpoint, when they're refusing to fund your data portion, how we can engage our patients to kind of pressure the system for us.
I personally think, as you said, primary care is overworked, and this work won't work well in the current primary care paradigm. And it really does come to creating a new paradigm for which we can get this work going. A lot of it, I think, should be powered by not the physician necessarily, but APP, pharmacists, et cetera, who are helping manage medications, and a more comprehensive healthcare team that can do this. I think the data science piece is putting all that data in a way that these teams can actually work with it. Like if AI is taking all of the patient data and saying these are the highest risk patients, then that APP knows, or the pharmacist knows who to go after and can be more efficient with their time.
Two more questions, maybe one back there.
Okay. Well, thank you everyone for joining.